Hello and welcome to the Unit 15 lecture on grief and loss. These are your learning objectives for the unit. Please review them in preparation for class and for the exam. So loss is felt by all individuals at some point or another and represents an actual or potential situation where something valued is changed or gone. Losses can be minor to significant and can cause brief sadness to long-lasting distress and depression. A loss is either material or psychological, or a combination of the two. Material losses are losses of a tangible object or possession, such as personal possessions in a house fire, while psychological losses do not have a physical form, but do have an important symbolic meaning. In the instance of a mastectomy, the loss is a combination. A person has the material loss of breast tissue, along with possible psychological loss of their feelings of sexuality. Grief is an emotional response to loss. There are several terms related to grief. Mourning includes outward, socially expressed behaviors exhibited after the death of a loved one, and practices vary from culture to culture. Bereavement is the state of desolation after a loss, particularly of a loved one. It's the total response to the loss and includes emotional, physical, social, and cognitive responses from an individual. Anticipatory grieving is a pattern of psychological and physiologic responses to a real or imagined impending loss of a loved one, relationship, or object. This occurs before the actual loss happens, and it can help the person cope with the actual loss when it finally does happen. The text lists several grief models. We'll focus on the Kubler-Ross theory. This particularly relates to dying and is made up of 5 stages: denial, anger, bargaining, depression, and finally acceptance. It's important to note that the person can go back and forth in the stages rather than progressing in a linear fashion through the stages. Make sure you're familiar with these stages. This diagram lists Kubler-Ross theory and some behaviors people might have during each stage. This diagram is off the nurselabs.com website. So there are several types of grief. Some are functional and some are dysfunctional. Normal grief includes resentment, sorrow, anger, crying, loneliness, and temporary withdrawal from activities. Anticipatory grief occurs prior to the death or loss, as we talked about previously. Complicated grief is grief that doesn't resolve as typical grieving should. The individual might have distress that impairs their ability to function properly. Types of complicated grief are listed on the slide. That's the chronic, delayed, exaggerated, and masked grief. So an individual's resources, such as financial status, developmental level, and intrapersonal support systems available, helps to determine their response to grief or loss. Infants and toddlers have no concept of death. So death, if their main thing is just the separation anxiety, they don't understand that the person's gone, but they understand that they're not close to them anymore. Preschoolers and school-age children think death is reversible and avoidable. Adolescents begin to realize that death is real and final, but they often are in denial that they could die, and that thought's too overwhelming, so they just tend to not think about it. Adults grieve death and then move on, provided their grief follows normal patterns, which we'll talk about in a while. Older adults might have several losses at once. For example, death of a loved one, like a spouse, the need to move to different housing, or retirement, and because of this, they might not cope as effectively. It's harder to cope with things when there's a buildup of different losses happening. Patients should be encouraged to think about and reach out to support systems to help them through the grieving process. Now keep in mind that the elderly might not have as many people in their support system, so they might rely on healthcare workers for their support system. The nature of the loss is also going to influence the individual response to grief. So for example, a traumatic loss such as with murder or a car accident might be more difficult to get over than a slower death as seen with a patient on hospice, and this can cause a complicated grieving process. Questions about loss should be a part of a nursing assessment. This slide lists various components to assess with your patients as well as their families. Be sure to assess normal patterns such as belief systems, especially spiritual or faith systems, and whether they have been helpful or unhelpful in the past. Resources, stressors, and social support. It's equally important to assess for dysfunctional patterns such as suicide planning or alcohol and drug abuse. Keep in mind that it might be difficult to identify dysfunctional patterns on the first visit, and the nurses need to be vigilant not only to apply, or not only to do the assessments, but we don't want to apply inappropriate labels to patients who are grieving differently than the nurse would. It's important to let the patient guide their end-of-life preferences if they're able to. We'll want to assess what's important to them and try to collaborate on ways that the patient can continue to do what's important to them, even at the end of life. So here's some nursing diagnoses that would be appropriate for individuals experiencing loss, grief, or death. And then nursing interventions to assist patients with grief are going to vary depending on their stage of grief. Health promotion interventions include assisting in learning to deal with their loss, to make effective decisions, and to adjust to the disappointment, anxiety, or anything else from the loss. Encourage them to express their feelings and work through them. Encourage effective coping skills such as support groups, and watch for ineffective coping such as alcohol and drug use, as well as poor nutrition. Now, palliative care is aimed at improving the patient's and family's quality of life when they're faced with life-threatening illness. Palliative care is important to initiate early in the course of illness, and it can work along with other treatments intended to prolong life. So the patient can be a full code and receive palliative care. The goal is prevention and treatment of suffering and combines psychological and spiritual aspects of care in a team approach. Hospice care, on the other hand, is intended for dying patients and their families. Patients qualifying for hospice have a life expectancy of 6 months or less. Treatment focuses on symptom relief rather than life-prolonging therapies and treatments. So the patient needs to be a DNR or do not resuscitate to qualify for hospice. So how do we as nurses know when our patient's dying? Well, there's several physical signs that can be observed. Skin becomes cool, pale, mottled, cyanotic, or jaundiced. And the picture on the slide is a picture of mottled skin. Heart rate becomes irregular and might speed up initially, followed by a decrease. Respirations become shallow and may be labored or irregular, or may rattle, and this is a fluid buildup in the airways that the patient's not able to cough out. Urine output decreases or stops, as does stool output. Patients lose their appetite. Now, families can be reassured that their loved one is not hungry, and feeding them might cause discomfort because their bowels are slowing down as well. The patient might be restless, anxious, or somnolent, or have a decreased level of consciousness. It's always important to remember that hearing is the last to go, so treat every patient as if they can hear you. Encourage family to touch and talk to their loved ones. It's also important to look for nonverbal indicators of pain, such as grimacing or restlessness, and treat the patient appropriately. The patients might not be able to tell us they're in pain, but they might still be having pain. It is important to remember that each patient has a unique progression of death and dying. No two patients are going to be the same. Now, when you perform post-mortem or after-death care on a patient, we want to do so with dignity and sensitivity. This often includes washing the body, changing linens, and preparing the body for the family to see. If the patient died unexpectedly, various IV lines and tubes will probably need to be left in place. This is in case the medical examiner needs to see the patient. To the extent possible, when you're caring for a deceased patient, this is my personal practice, is that I would elevate the head of the bed and place the patient's hands on top of the bed linens to allow the family to touch the patient if they want to. This simple act tells the family that it's okay to touch the patient. Otherwise, they might miss out on this opportunity for closure and saying goodbye. Now, we want to be sure to reflect on how we as nurses are feeling about and dealing with a patient's death. This can be a strongly emotional time for staff as well as patients and families. It is important, however, to try to be a source of support for your patient's family rather than them needing to support you. Be sure to draw on support from co-workers if needed, and don't rely on the patient's family to console you during their time of grief. It's essential to determine if a patient has an advance directive. This tells healthcare providers what the patient wants done in the event that they're not able to make their wishes known due to an illness or accident. If they don't have an advance directive, provide them with information about why they're important. Patients have the right to declare their personal wishes. Advance directives are not just for those nearing death. I would encourage each of you to complete an advance directive if you don't already have one. Otherwise, how will you make your healthcare wishes known if you can't talk for yourself? You don't want the state making those decisions for you. Advanced directives are available for free at any healthcare center, and you can download them online also free of charge. The two types of advanced care directives are living will, which outlines the client's wishes regarding healthcare received if they're unable to communicate, and a durable healthcare power of attorney. This outlines the person the patient chooses to manage the healthcare decisions on their behalf if the patient's unable. The patient completes several questions about treatments that they would or would not be okay with, such as feeding tubes, nursing home placement, or ventilator support. So DNR orders. The key thing with a DNR order is that they mean do not resuscitate or no CPR, intubation, or shocks. They do not mean do not treat. The patient still should be treated to the extent possible for their condition. With DNR, the providers are not hastening death. That means they're not trying to bring about death more quickly. They're simply allowing natural death to take its place if the patient's heart stops or they stop breathing. With euthanasia, however, they are bringing about death quicker than would be with natural causes by providing usually a lethal dose of a medication. It's important to note that euthanasia is illegal in most states. So this slide just outlines the ANA recommendations for DNR orders. Pause here and review the slide if you need to. And that concludes our presentation on grief and loss. The next one will be a presentation on spirituality. Thanks for watching and have a great day.